My name is Dr. Ekbendu. I am an internal medicine resident at Advent Health Sebring. I'm presenting a case titled The Stroke Seesaw, Unveiling the Enigma of Stuttering Acute Ischemic Stroke. According to Murphy and Waring in 2020, stroke is the second leading cause of death and disability globally. The American Heart Association's 2019 update on heart disease and stroke statistics revealed that in the United States, approximately 87% of all strokes are due to ischemia, while 10 and 3% of strokes are due to intracerebral hemorrhage and subarachnoid hemorrhage, respectively. Globally, approximately 90% of the stroke risk could be attributed to modifiable risk factors such as hypertension, hyperlipidemia, obesity, hypoglycemia, and renal dysfunction, while 74% could be attributed to behavioral risk factors such as smoking, sedentary lifestyle, and an unhealthy diet. We introduced an unusual case of a 70-year-old male with a past medical history of hypertension, hyperlipidemia, cigarette smoking, without prior stroke history, who initially presented to our facility with difficulty speaking, left lower extremity weakness, and left facial droop. Upon presentation, symptoms had resolved and the initial NIHS score was 0. Therefore, tissue plasminogen activator, or TPA, was deferred. In the ED, within 2 to 10 hours of his last known normal, the patient had multiple recurrent episodes of left-sided weakness, left facial droop, and dysarthria, occurring about every 20 minutes. Each episode lasted 30 to 45 seconds with a return to baseline neurologic status. He again had similar neurological deficits later the same evening of hospital day 1, between 11th to 12th hour of his last known normal. Initial CT and MRI of the brain obtained on hospital day 1, as seen below, showed no acute hemorrhage or infarcts. CTA of the head and neck showed moderate bilateral internal carotid artery stenosis, as depicted in figure 4 below. By hospital day 2, he had no further episodes of focal neurologic deficits. He was treated appropriately with aspirin, clopidogrel, and high-dose statin, and discharged without symptoms on hospital day 3. Notably, though, the patient returned to our facility after 3 days of discharge with progressive slurred speech and bilateral lower extremity weakness. TPA was again not given since symptoms had been ongoing for days. Repeat CT of the brain showed no intracranial hemorrhage. However, this time, repeat MRI brain revealed acute infarction located in the mid-pons, as depicted in figure 3 below. He was continued on aspirin, clopidogrel, and high-dose statin therapy. On hospital day 8, he was discharged with dysarthria to inpatient rehabilitation with scheduled outpatient follow-up. The fluctuating pattern of focal neurologic deficits seen in this patient is what we refer to as stuttering. And according to Kaplan in 2022, the stuttering pattern is normally seen in thrombotic or cardioembolic strokes. Our patient's pontine ischemic stroke may have resulted from a combination of atherosclerosis, small vessel disease, alongside his risk factors of hypertension, hyperlipidemia, and smoking. Lysis and frequent migration of a thrombus might have led to the stuttering symptoms noted in our patient. We highlight this case to bring attention to a stuttering atypical presentation of ischemic stroke not previously well described in the medical literature. Our case demonstrates that stuttering stroke presentations may imitate a more short-lived neurologic events such as transient ischemic attacks, or TIA. Therefore, in this context, we recommend that all the patient events along the entirety of the patient's time course be reviewed quickly and thoroughly. TPA can then be considered in the earliest window of opportunity for patients with stuttering stroke presentations to prevent disability due to ischemic stroke. Thank you.